Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very exciting topic, the medullary syndromes and cruciate hemiplegia. Generally, we all know the hemiplegia wherein one side of the body gets affected, left upper limb, left lower limb, or right upper limb, right lower limb. But medulla oblongata lesion can produce a very strange lesion known as cruciate hemiplegia, wherein hand of one side and leg of the other side get affected. That is known as cruciate hemiplegia, the details of which I will talk about in this lecture. But before I actually begin the lecture, I want to talk about a very interesting and exciting point just to generate interest in students and young residents. Though I'll be talking about it in detail in the due course of my lecture. We have the sympathetic tract running in the entire brainstem, midbrain, pons and medulla oblongata. But when there is midbrain lesion, there is actually dilatation of the pupil. When there is a pontine lesion, there is bilaterally small pupils. And when there is medulla oblongata lesion, there is a unilateral small pupil. So though the sympathetic tract runs across the brainstem, midbrain, pons and medulla oblongata, the clinical manifestations of the pupil and its size and the side varies. What is the explanation for it? The midbrain causes pupillary dilatation. Though we have the sympathetic tract in the midbrain. Why? I can give you an example. After death, though the parasympathetic and sympathetic gets affected, the pupil is dilated after death. So though the parasympathetic and sympathetic are affected, and parasympathetic causes constriction of the pupil and sympathetic causes dilatation of the pupil, and hence since both of the tracts, parasympathetic and sympathetic, are affected, the pupil should be mid-size. But what we see clinically is that after death, the pupil is dilated. What is the explanation for this? The explanation is that though the pupil is controlled both by parasympathetic and sympathetic, it is the parasympathetic which controls the pupil more than the sympathetic. And therefore, after death, though the parasympathetic and sympathetic get affected, since the parasympathetic control over the pupil is more than the sympathetic, and since the parasympathetic which causes constriction of the pupil is its main role is affected, it causes dilatation of the pupil. So the explanation is that though parasympathetic and sympathetic control pupil, it is predominantly the parasympathetic which controls the pupil than the sympathetic. And therefore, in a midbrain lesion, though the parasympathetic and sympathetic can get affected, it is the parasympathetic which has got a profound influence on the pupil, and therefore since the parasympathetic fibers which run on the third nerve in midbrain which is affected, so pupil is dilated in the midbrain irrespective of sympathetic tract being affected or not. Right. The second point is that in pontine lesion, like pontine hemorrhage, we see bilateral small pupils. But in medulla oblongata, we see only a unilateral small pupil, that is on one side. Whereas in pons, we see pupils on both sides being small, pinpoint and small size. What is the mechanism? Pons is supplied by a single basilar artery. Pons is supplied by a single basilar artery, unlike medulla oblongata, which is supplied by two vertebral arteries. And therefore, a single artery being affected is more common than two arteries getting affected. And therefore, the pons which is supplied by a single basilar artery, if it gets affected like pontine hemorrhage or basilar artery thrombosis, both the sympathetic tracts get affected. So it produces bilateral HORNER'S syndrome. So both the pupils get constricted. So this is a wonderful explanation. There is bilateral HORNER'S syndrome in pontine lesion because pons is supplied by a single artery, that is the basilar artery. Whereas in medulla is supplied by both the medulla. You have medulla. So single, you have the two vertebral arteries. So this medulla oblongata is supplied by vertebral artery. This medulla oblongata is supplied by vertebral arteries. So the two vertebral arteries getting affected, or both the pica arteries getting simultaneously affected, is very, very rare, and only one side usually gets affected, pica of a vertebral artery, and sympathetic tract on that side gets affected. So in Wallenberg's syndrome, the lateral medullary syndrome, we see a small pupil only on one side. So this is a wonderful explanation, and this is the beauty of clinical neurology. If we know concepts, it's really interesting, exciting, and mind-blowing. So though the sympathetic tract runs from midbrain, pons, and medulla in the entire brainstem it transects, it goes through. Each part of the brainstem produces a different clinical manifestation. Midbrain produces a dilated pupil, pons produce bilateral small pinpoint pupil, whereas medulla, that is lateral medullary syndrome, Wallenberg syndrome, produces pupillary constriction only on one side. So just to generate interest, I told about these wonderful clinical concepts and the beauty of clinical neurology. Let's go to the lecture, Wallenberg syndrome and Cruciate Hemiplegia and medial medullary syndrome. Right, this is the medulla oblongata. So basically there are two syndromes, medial medullary syndrome, lateral medullary syndrome. As the name suggests, medial medullary syndrome affects the medial part of the medulla oblongata, and the lateral medullary syndrome, that is Wallenberg syndrome, affects the lateral part of the medulla. The three important structures which get affected in the medial medullary syndrome, that is the medial part of the medulla oblongata, first is the corticospinal tract, which is placed medially. So when the corticospinal tract gets affected, there is contralateral hemiplegia. The second is the 12th nerve gets affected. 12th nerve supplies the tongue. For example, if my right side Wallenberg syndrome is there, when my right side 12th nerve gets affected, the tongue is not pushed to the left side. In fact, it is pulled to the same side. Why? The action of genioglossus is pushed to push the tongue to the opposite side. So when the 12th nerve gets affected, the tongue is pulled towards the same side. And third, the posterior column gets affected. The medial lemniscus, which carries position, joint, and vibration sense. So these three parts, these three structures get affected in the medial medullary syndrome. So what are the structures? First is the corticospinal tract, which gets affected, produces contralateral hemiplegia. Second, the tongue, 12th nerve gets affected. It is pulled towards the same side because the action of the genioglossus is to push the tongue to the opposite side. And third, the posterior column, medial lemniscus, gets affected. So position, joint, vibration sense is lost on the opposite side. The blood supply of the medial part of the medulla oblongata is the anterior spinal artery. I said in the medial medullary syndrome, the posterior column is affected. The spinothalamic tract lies laterally in the medulla oblongata. So in the medial medullary syndrome, the posterior column gets affected, but spinothalamic tract is not affected because spinothalamic tract is laterally placed. So again here we have dissociation of sensations. The sensations carried by posterior column are lost because posterior column medial lemniscus is medially placed, but the sensations carried by spinothalamic tract, pain, temperature, sensation, are spared because spinothalamic tract is placed in the lateral part of the medulla. So other than this medial medullary syndrome, what are all the other conditions which selectively affects the posterior column or the sensations carried by posterior column or large fibers, namely position, joint, vibration sense? The first is, so position, joint, vibration sense are otherwise known as epicritic sensations. So epicritic sensations are lost, and sensations carried by spinothalamic tract or small fibers, that is pain, temperature fibers, otherwise known as protopathic sensations, are spared. So the conditions where the protopathic sensations are spared but epicritic sensations, that is position joint vibration sense carried by posterior column, are lost are: 1. The medial medullary syndrome, wherein the posterior column which is placed in the medial part of the medulla oblongata gets affected. So the conditions where selectively the position joint vibration sense affected are: 1. The medial medullary syndrome. 2nd, Guillain-Barré syndrome, GBS. Guillain-Barré syndrome is an autoimmune disorder affecting the peripheral nerves. It's a demyelinating disorder. The posterior column and pyramidal tracts are well myelinated tracts. The spinothalamic tract is the least myelinated tract. And therefore in Guillain-Barré syndrome, which is an autoimmune disorder affecting the myelinated tracts, since the posterior column is well myelinated, since the peripheral nerves are well myelinated, the large fiber peripheral nerves are well myelinated, so only the sensations carried by large fibers, namely position joint vibration sense, namely the protopathic sensations, are lost. And third, B12 deficiency and B6 deficiency. Here also the large fibers are affected, position joint vibration sense are affected. The other conditions being tabes dorsalis, neurosyphilis. And then when we come to the spinal cord, the posterior columns are placed posterior most. So if the posterior spinal artery supplying the posterior column gets affected in the spinal cord, again there is selective loss of posterior column but sparing of spinothalamic tract sensations. So very important MCQ question and very important point clinically, which has got good concepts. So what are the conditions where the epicritic sensations, namely position joint vibration sense, are lost but protopathic sensations, pain and temperature sense, are spared? 1. The medial medullary syndrome. 2nd, the Guillain-Barré syndrome. 3rd, B12 B6 deficiency. 4th, tabes dorsalis. 5th, posterior spinal cord syndrome. Right. This is all we need to know about medial medullary syndrome. Now let's come to the favorite question of the examiners, the lateral medullary syndrome and the Wallenberg's syndrome. So what are the structures which are affected in the lateral medullary syndrome and what are all the clinical manifestations? Here there are 6 important structures in the lateral medulla. The first is the inferior cerebellar peduncle. So when the inferior cerebellar peduncle gets affected, person will have ataxia. So person will have ataxia. The second is that the vestibular nucleus of the 8th nerve gets affected. We all know that vestibular nerve is concerned with balance, and therefore when the vestibular nucleus of the 8th nerve gets affected, 8th nerve is placed in the pontomedullary junction. So when the vestibular nucleus gets affected, person will have nausea, vomiting and vertigo, severe vertigo. Right. The third is the sympathetic fibers. So when the sympathetic fibers get affected, sympathetic fibers are the fibers responsible for dilatation of the pupil. So when the sympathetic fibers get affected, you get meiosis or small pupil, which you call it as HORNER'S syndrome. So HORNER'S syndrome can get affected in the 3 particular areas, the 3 orders. Either the first order can get affected, wherein the medulla oblongata gets affected, lateral medullary syndrome, syringomyelia, that is from the hypothalamus to C8T1, or in the second order from C8T1 to the superior cervical ganglion, that is lung apical tumor, or beyond the ganglion, that is in the carotids, where there is carotid artery dissection. So HORNER'S syndrome can occur in the 3 places, in the 3 orders. In the first order, it could be in the medulla oblongata, that is unilateral HORNER'S syndrome, or it could be in the pons, as I said in the early part of my lecture, where there is bilateral HORNER'S syndrome. Second, in the second order, that is the apical lung tumor. Third is in the carotid artery, causing carotid artery dissection. Right, this is about the sympathetic tract. Then, as I said about the pupil, though the sympathetic tract runs in midbrain, pons and medulla oblongata, a midbrain lesion causes pupillary dilatation, because parasympathetic fibers which run on the third nerve got more control of the pupil than the sympathetic, and therefore whether the sympathetic gets affected or not, if the third nerve gets affected, the parasympathetic fibers get affected, there is dilatation of the pupil in the midbrain. Whereas pons is supplied by a single basilar artery, both the pons are supplied by a single basilar artery with its branches, and therefore it is very likely for a single artery to get affected. So both the sympathetic tracts get affected. There is bilateral HORNER'S syndrome, so bilateral small pinpoint pupils. Whereas in the medulla oblongata, it is supplied by only one artery, that is a vertebral artery or posterior inferior cerebellar artery. So only one side sympathetic tract gets affected. Unilateral HORNER'S syndrome causing pupillary constriction meiosis in the Wallenberg's syndrome. The next structure to get affected is the nucleus ambiguous, which is the 9th and 10th nerve. So if 9th and 10th nerve gets affected, they can have dysarthria and dysphagia. Then you can have the spinal tract of the trigeminal nerve getting affected. So when the spinal tract of the trigeminal nerve gets affected, they'll have ipsilateral loss of pain and temperature over the face. And finally, we can have the spinothalamic tract which being affected. The spinothalamic tract carries pain and temperature sensation. So when it gets affected, you have pain and temperature loss on the opposite side. The medial part of the medulla oblongata is supplied with the anterior spinal artery, but the lateral medulla is supplied with the pica, posterior inferior cerebellar artery, a branch of vertebral artery. Here there are two important points in lateral medullary syndrome. One, the corticospinal tract will never get affected in lateral medullary syndrome or Wallenberg's syndrome, because the corticospinal tract is medially placed. And therefore, one of the commonly asked questions, will there be hemiplegia in Wallenberg's syndrome? The answer is no. Hemiplegia is not seen in lateral medullary syndrome or Wallenberg's syndrome because corticospinal tract is medially placed, whereas Wallenberg's syndrome, the lesion is in the lateral part of the medulla. So corticospinal tract is never affected and hemiplegia is not seen in Wallenberg's syndrome. Second, I said the spinothalamic tracts are laterally placed and posterior column are medially placed. So in Wallenberg's syndrome, the spinothalamic tract gets affected, but posterior column gets spared, which is medially placed. So the sensations carried by the spinothalamic tract, namely pain and temperature, that is the protopathic sensations, are lost. So now the question comes, what are all the other conditions where protopathic sensation, that is pain and temperature, are lost, but epicretic sensation, position joint vibration sense, are spared? The first point is that lateral medullary syndrome, the Wallenberg syndrome, because the sympathetic tracts are laterally placed, but the posterior column are medially placed, and hence a lesion in the lateral part of the medulla oblongata will selectively affect the spinothalamic tract, and therefore there is a loss of protopathic sensations, but epicretic sensations are present. Second condition which we commonly encounter in our clinical practice is peripheral neuropathy. The cause of peripheral neuropathy, 1/3 are because of diabetes, 1/3 are because of other medical conditions, and 1/3 we do not know the cause, idiopathic. So diabetic peripheral neuropathy is one of the common clinical conditions we encounter, and diabetic peripheral neuropathy usually affects the small fibers. So pain and temperature are lost, but position joint vibration sense are spared. The other condition being peripheral neuropathy, especially diabetes. Third is the syringomyelia, again one of the commonly asked questions. In syringomyelia, there is a cavity in the center of the spinal cord. Therefore, it affects the crossing spinothalamic tract fibers, but spares the posterior column sensations. So syringomyelia is one other conditions where the pain and temperature sensations carried by spinothalamic tract are affected, but position joint vibration sense are spared. And the other condition is in the spinal cord. We have the posterior column placed posteriorly, which is supplied with the posterior spinal artery. Other than posterior column, all other sensations, that is the spinothalamic tract and motor fibers, pyramidal tract, are all supplied by the anterior spinal artery. So if there is anterior spinal artery involvement, the spinothalamic tract gets affected, but posterior column is spared because posterior column is supplied by the posterior spinal artery. Again, a very important question, clinical question, which beautifully explains the clinical neurology. So what are all the conditions which causes a selective loss of protopathic sensations but spares the epicritic sensations? That is, pain and temperature are lost but position joint vibration sense are spared. One is the lateral medullary syndrome, that is syringomyelia, the lateral medullary syndrome, that is Wallenberg's syndrome. Second is the diabetic peripheral neuropathy. Third is the syringomyelia, and fourth is the anterior spinal artery syndrome, wherein posterior column fibers are spared because they are supplied by posterior spinal artery. So this is in nutshell about the medullary syndromes. Now let me talk about a very fascinating clinical manifestation, cruciate hemiplegia. This occurs in medulla oblongata only because of the peculiarity of the corticospinal tract fibers. The corticospinal tract fiber begins in the bed cells of the fifth layer of the motor cortex and crosses at the level of the medulla oblongata and goes to the opposite side. 90% of the fibers cross, but 10% of the fibers do not cross. So the fibers of the corticospinal tract cross at the level of the medulla oblongata. Not all the fibers cross equally. The upper limb fibers cross above and the lower limb fibers cross below. The arm fibers cross above and the leg fibers cross below. So here, because of this, we have a peculiar clinical presentation, cruciate hemiplegia, wherein one side arm, hand, the other side leg is affected. So either right arm and left leg, or left arm and the right leg can get affected. How do we explain this? The arm fibers cross above and the leg fibers cross below. So if there is a lesion here where the arm fibers cross, they can have selective upper limbs involvement only. If there is a lesion here where the leg fibers cross, only leg fibers get affected, they can have selective paraplegia. So cerebral causes of paraplegia are two conditions. One in the cortex, medial part of the frontal cortex, where the leg area is supplied by the anterior cerebral artery. So if both anterior cerebral arteries get affected, there can be selective paraplegia. Second is in the medulla oblongata, where there is a lesion where the leg fibers cross, only the legs get affected. So the two cerebral causes of paraplegia are one, the anterior cerebral artery, both the anterior cerebral artery involvement, and second in the medulla oblongata, where the leg fibers cross caudally. But if there is a lesion here, wherein the leg area on one side which is uncrossed, and the second, the arm fibers which are just crossed, if they get affected, we have a very peculiar combination of here, right leg and left arm can get affected. Likewise, if there is a lesion here, right arm and left leg can get affected. So right arm and left leg, or left arm and right leg can get affected if there is a lesion here wherein uncrossed leg fibers and crossed arm fibers get affected. This is known as cruciate hemiplegia. One side arm, the other side leg. One side arm, the other side leg. This is cruciate hemiplegia. It occurs in medulla oblongata. So these are all the important essential points of medullary syndromes and cruciate hemiplegia. The two important essential exam-oriented points and clinically exciting and important points are: one, the pupil. So though the sympathetic tract runs in its entirety from midbrain, pons and medulla and the entire brainstem, the clinical manifestations are different in each part of the brainstem, that is midbrain, pons and medulla oblongata. In midbrain it produces dilated pupil. In pons it is bilateral HORNER'S syndrome because a single artery supplies pons. So you have bilaterally small pinpoint pupil. In medulla oblongata it is a unilateral HORNER'S syndrome because medulla oblongata is supplied by a single artery, vertebral artery or pica artery. The second is that the sensory loss. There could be a loss of epicritic sensations and presence of protopathic sensations, or loss of protopathic sensations and presence of epicritic sensations. If epicritic sensations, that is position joint vibration sense, are lost because of posterior column, the conditions are the medial medullary syndrome, the Guillain-Barré syndrome, vitamin B6, B12 deficiency, tabes dorsalis and posterior spinal artery syndromes. The conditions wherein pain and temperature, that is protopathic sensations, are lost but position joint vibration sensors are spared are the lateral medullary syndrome or Wallenberg's syndrome, peripheral neuropathy, the diabetic peripheral neuropathy, syringomyelia, and the anterior spinal artery syndrome. But one of the commonly asked favorite MCQ questions about the medulla and the medullary syndromes is that hemiplegia or the corticospinal tract is not seen in the lateral medullary syndrome because corticospinal tract is medially placed. So hemiplegia or corticospinal tract involvement is not a feature of lateral medullary syndrome or Wallenberg's syndrome. I hope I enjoyed giving this lecture, and I hope you have also enjoyed listening to this lecture. If you have any suggestions or comments, kindly post onto my channel. Please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.